Welcome to the training module on corticosteroids for community-acquired pneumonia, or CAP. At present, this is the only treatment comparison for CAP in recovery, so I'll start by explaining how we define CAP and the reasons we're evaluating corticosteroids. Then I'll describe the recovery corticosteroid comparison. In a non-pandemic context, CAP requiring hospital admission is usually caused by bacteria that get into the lungs from the upper respiratory tract. The causative pathogens are usually not identified in routine practice, especially not at the time of admission, so diagnosis tends to be based on typical symptoms, plus radiological evidence of lung involvement, such as this chest x-ray with right upper lobe consolidation. And treatment is with empirical antibiotics and supportive care. The recovery CAP comparison is recruiting these patients, with CAP related to suspected or confirmed bacterial infection. CAP is one of the commonest reasons for acute hospital admission, and is the fourth leading cause of death worldwide, estimated by the WHO to kill around 2.5 million people per year. Viral pneumonia caused by SARS-CoV-2 and influenza have different pathologies and treatments, and they can be readily diagnosed by throat swab PCR, so are treated as separate categories of pneumonia in recovery. This slide shows the current recovery eligibility criteria for all comparisons, with the CAP category highlighted. All recovery patients must be hospitalised with a pneumonia syndrome, and we would expect this to include typical symptoms of a new respiratory tract infection, such as cough, shortness of breath and fever, as well as some objective evidence of lung involvement. This would usually be radiological, but could also be demonstrated by new hypoxia or clinical examination. Alternative diagnoses other than pneumonia, such as heart failure, should be considered unlikely or excluded, but note that the diagnosis of pneumonia is ultimately at the discretion of the managing doctor. Patients with pneumonia must also have one of the three diagnoses here, which will determine the treatment comparisons available. The COVID and influenza categories are greyed out because I'm not discussing these. And the third category is for patients with CAP, who should have a diagnosis of community-acquired pneumonia with planned antibiotic treatment and no suspected or confirmed COVID, influenza, PCP or TB, as discussed in a minute. Patients should have no medical history that in the opinion of their doctor would put them at risk if they were to participate, and if their doctor thinks that a trial treatment is either indicated or contraindicated for any reason, they're not eligible to join that comparison. In the case of the corticosteroid comparison, this would include any systemic glucocorticoid treatment, not just dexamethasone. Note that in addition to these universal criteria, some treatment comparisons have their own specific eligibility or exclusion criteria. Regarding CAP eligibility and recovery, patients are ineligible if they have suspected or confirmed SARS-CoV-2 or influenza infection because there are different treatment comparisons for pneumonia caused by these viruses, or if they have suspected or confirmed pneumocystis jirovecii pneumonia, also known as PCP or PJP, or active pulmonary tuberculosis. And this is because these two infections have distinct pathologies, and steroids are of proven benefit in PCP. However, testing for these pathogens is not required for trial purposes, so this should only be done if it's done as part of standard care. If any tests for these pathogens are sent with a low clinical suspicion, then it's not necessary to wait for the results, even though this could mean they're occasionally diagnosed after enrolment. We also realise that the recovery CAP eligibility criteria will exclude some patients with bacterial pneumonia secondary to flu or COVID. Detection of viruses other than those above is not an exclusion. For example, viruses usually associated with mild upper respiratory infection, like RSV, adenovirus or rhinovirus. And the term community-acquired can be defined as in usual clinical practice, but should imply that pneumonia was present on admission, and that the patient hasn't recently been an inpatient in hospital or a healthcare facility, for example in the past 10 days before admission. Moving on to describe the rationale for testing steroids. We know that dexamethasone 6 mg reduces mortality in hypoxic COVID patients by around 1/5, and even more in those requiring invasive ventilation. Corticosteroids are also beneficial in patients with HIV and severe PCP. However, despite similarities with COVID, lung involvement is typically more focal in CAP, with less severe hypoxia and different patterns of immune activation. CAP is also a more heterogeneous syndrome than COVID, particularly as it's caused by a variety of pathogens. So the question we'd like to answer is, do corticosteroids reduce mortality in patients hospitalised with CAP? Several randomised trials have tried to test corticosteroids in CAP before, and these are shown here from a systematic review published early in 2023. This forest plot shows a summary of the trials, and in case you're not familiar with these plots, each row represents a separate trial, with the effect on the risk of death shown as small red squares in the figure. Squares to the left of the line indicate a benefit of treatment, and the horizontal lines through each square represent the amount of uncertainty in each trial. So combining the results from all of these trials shows that steroids were associated with a risk of death of 0.85, or a 15% reduction. But because the number of patients is too small, they don't provide good evidence that steroids reduce the risk of death at all, and also don't rule out a really large benefit, such as reducing the risk of death by a third. Since that review was published, another randomised trial has been reported that seemed quite promising. There was a lower risk of death with steroids in the 2023 Cape Cod trial of ICU patients with severe CAP, with 25 versus 47 deaths in favour of steroids, which is quite statistically significant. But there was no favourable effect among ICU patients in the similarly sized ESCAPE trial published a year before, with 47 versus 50 deaths. And as such, we still don't have conclusive results to guide treatment. It is known from placebo-controlled trials that corticosteroids reduce the time to discharge in CAP, but this may be because of the fairly large effect that steroids have on fever and CRP reduction, rather than representing an improvement in outcomes. And in fact, there's some evidence that readmissions may actually be higher in those allocated corticosteroids. So despite the fact that CAP is common, with millions of people admitted to hospital every year, fewer than 5,000 have been included in these trials. With COVID, we saw that much larger numbers were needed to identify or rule out a worthwhile benefit of treatment. And in recovery, we expect that we'll need to recruit more patients than all previous trials combined to produce a clear answer. So we need more randomised evidence from a wide range of patients to inform global treatment of CAP. The recovery CAP steroid comparison. This picture shows all current treatment comparisons in recovery, grouped by the category of pneumonia. After baseline data is collected and suitability is determined, patients are randomised in each suitable treatment comparison, with each randomisation being independent of the others. At the top left are the two remaining COVID comparisons, and at the bottom are the three comparisons for influenza. And note that some of these comparisons might not be open at your site or in your region. At the top right is the CAP steroid comparison, which is a randomisation between dexamethasone and usual care without corticosteroids. CAP corticosteroid comparison is only open to adults aged at least 18, but otherwise there are no specific eligibility criteria for this comparison. In contrast to the influenza steroid comparison, there is no requirement for hypoxia, as this is less likely to be a reliable marker of severity in bacterial infection, and it hasn't been required in most other CAP steroid trials. Pregnant and breastfeeding women are eligible, but prednisolone or hydrocodone should be used instead of dexamethasone, as they produce less infant and fetal exposure. Dosing for these is in the protocol. Patients with renal or liver failure are also eligible. As mentioned earlier, patients are not eligible if their attending doctor considers systemic corticosteroids to be indicated or contraindicated for any reason. This could include indications like COPD exacerbation, but may also include ones where practice is more variable, such as steroids for septic shock or for CAP itself. We know that use of steroids in hospitalised patients may differ widely between clinicians, and we want to enrol the whole range of patients where there's uncertainty. This may lead to a relatively heterogeneous trial population, but if there are important differences in steroid efficacy between groups, for example by level of respiratory support, this should become apparent in the analysis. Contraindications are also left to the clinician's discretion based on their usual practice, for example avoiding steroids in those considered to be at particularly high risk of side effects. If, after randomisation, corticosteroids become indicated in a patient allocated usual care, then these should be given, as clinicians should always act in their patient's best interests, even if it means starting, stopping or modifying a trial treatment. However, if patients are enrolled correctly, This should only be happening because of a change in clinical condition after randomization. And it's very important for the trial that we don't enrol patients if it's foreseeable that either possible allocation wouldn't be followed. Dexamethasone is a CYP3A4 substrate, so there's an increased risk of exposure and steroid side effects if it's given alongside potent inhibitors, for example clarithromycin or erythromycin, which are of particular relevance as they're often used for the treatment of CAP. But note that azithromycin, another macrolide, has a similar spectrum and is used for CAP treatment, but it doesn't interact with dexamethasone. Other major inhibitors include ritonavir and cobicistat, often found in antiretroviral regimens, and azole antifungals. If the patient's on a potent inhibitor, consider whether it can be safely stopped or replaced, or if increased monitoring for steroid side effects would be needed. If a potent inhibitor can't be avoided, then it may not be appropriate to enrol the patient in the corticosteroid comparison, but this isn't prohibited by the protocol, as management should be based on an assessment of individual risks and benefits, with local expert advice if needed. The steroid treatment regimen is the same as in the influenza steroid comparison and our original COVID steroid comparison, which is 6 mg of dexamethasone daily by mouth, nasogastric tube or IV, and treatments for 10 days or until discharged, whichever sooner. Note that no samples are needed from patients in the CAP comparison. Physicians managing acute medical patients will be familiar with potential steroid side effects, and these should be anticipated and managed as they would be in normal practice. For example, hyperglycemia is common, particularly in those with diabetes, so consider whether there's any need for increased monitoring. Steroids increase the risk of gastrointestinal bleeding somewhat by about 30 or 40%, so consider the need for gastroprotection in those at high risk. Whilst on steroids, patients will be at increased risk of opportunistic infection, especially if they have other reasons for immunosuppression. Psychiatric reactions can occur, particularly in those with a psychiatric history, and so can fluid retention. And finally, some patients may be at risk of adrenal insufficiency with sudden steroid withdrawal, for example, those with significant previous steroid use or other reasons for adrenal insufficiency. And if so, consider a gradual withdrawal of dexamethasone following normal practice. In summary, CAP is a major cause of hospital admission and death worldwide, and if corticosteroids reduce the risk of death even moderately, say 10 to 20%, it could save tens or hundreds of thousands of lives. But to identify or rule out a worthwhile benefit like this will require far more patients to be randomized than there have been in previous trials, so please consider recovery in as many of your patients as possible. Thank you for listening.